every crime is a wound on the world. We're here to dissect it, layer by layer, to find the truth buried within. This is Anatomy of Crime. The neonatal intensive care unit is a place of fragile margins. It is a sanctuary built on the precipice of life and death, where the air is filled with the rhythmic hum of ventilators and the relentless beeping of heart monitors. Here, premature and critically ill infants fight for every breath, their survival dependent on the tireless vigilance of specialized medical professionals. Parents place their ultimate trust in these individuals, believing implicitly that the hands tending to their vulnerable newborns are guided by the oath to do no harm. But what happens when that sacred trust is weaponized? What happens when the architect of a nightmare wears the uniform of a caregiver? Today, we dissect the anatomy of a medical betrayal. We will examine the chilling statistical anomalies in a regional hospital ward, the meticulous forensic analysis of insulin-poisoned intravenous bags, and the perplexing psychology of Britain's most prolific modern serial killer of children, neonatal nurse Lucy Letby. To understand the anatomy of this betrayal, we must first establish the baseline of the environment in which it occurred. The Countess of Chester Hospital is a large, busy facility in the northwest of England. Its neonatal unit was classified as a Level 2 center, equipped to care for babies born from 27 weeks gestation onwards. In a typical year, a unit of this size and capability might tragically see 2 or 3 infant deaths. It is the heartbreaking reality of neonatal medicine. However, starting in June 2015, a disturbing and inexplicable shift occurred. The mortality rate began to climb, but it was not just the frequency of the deaths that alarmed the senior pediatricians. It was their sudden and catastrophic nature. Babies who were stable, who were feeding and growing, would inexplicably crash. Their heart rates would plummet, their oxygen levels would drop dramatically, and resuscitation efforts, which should have been successful given their baseline health, inexplicably failed. The first shadow fell over the ward with the death of a baby boy, known in court documents as Baby A, in June 2015. He was born prematurely, but was considered to be in good condition. Less than 24 hours after his birth, he suffered a sudden collapse and died. The following day, his twin sister, Baby B, also collapsed but was successfully resuscitated. A strange physical manifestation linked these events: the sudden appearance of unusual, fleeting skin discolorations on the infants. Medical staff described it as a stark purplish mottling, almost like a rash that would appear and vanish rapidly. This was not a known symptom of typical neonatal infections or respiratory distress. It was an anomaly, a physiological scream that something unnatural was occurring within their tiny bodies. As the months progressed into the autumn of 2015 and the spring of 2016, the collapses continued. The consultants, led by Dr. Stephen Breary and Dr. Ravi Jayaram, began a desperate search for a medical explanation. They investigated potential viral outbreaks, bacterial infections, and environmental factors. They reviewed protocols and equipment. Every medical avenue led to a dead end. But as they pored over the case files, looking at the time of each collapse and the staff present on the ward, one singular, chilling common denominator emerged. It was not a piece of equipment, nor a faulty medication batch. It was a person. Nurse Lucy Letby was on duty for every single unexplained event. This pattern was not subtle. It was not a statistical whisper. It was a scream in the data. This brings us to the first core component of our anatomical dissection: the statistical anomaly. In a medical setting, correlation does not immediately equal causation. shift patterns are complex, and some nurses work more hours or are assigned to more intensive care rooms. However, the prosecution at Letby's trial would later present a document that became the cornerstone of their case, a staff shift rota cross-referenced with the times of the fatal and non-fatal collapses. It was a simple grid, a matrix of names and dates, but its implications were devastating. Across 24 distinct incidents involving 17 babies, Lucy Letby's name was the only one with a mark in every single column. When she worked days, the collapses happened during the day. When she was moved to night shifts to try and separate her from the pattern, the collapses moved to the night. An expert statistician could argue probabilities, but the sheer, overwhelming weight of this constant presence defied any innocent mathematical variance. She was the dark orbit around which these tragedies revolved. But statistics alone cannot convict a person of murder. The investigators of Operation Hummingbird, the police task force assigned to the case, needed to move from correlation to forensic certainty. They needed the physical anatomy of the crimes. Letby used a variety of methods, exploiting the chaotic and fragile nature of the neonatal ward. She was convicted of injecting air into the bloodstreams of several infants, a devastatingly effective method of causing an air embolism. In a tiny, premature cardiovascular system, a bolus of air acts like an impenetrable blockage. It stops the heart from pumping blood, leading to sudden, catastrophic cardiovascular collapse. Radiographs taken after some of the deaths showed inexplicable, unnatural accumulations of gas in the great vessels and hearts of the babies, a forensic footprint of an unnatural intervention. She also forced excessive amounts of milk and air down feeding tubes, causing agonizing internal distension and fatal splinting of the diaphragm, preventing the babies from breathing. But perhaps the most insidious and forensically complex method she employed was insulin poisoning. This brings us to the cases of baby F and baby L, two infants who survived Letby's attacks but provided the undeniable scientific proof of foul play. Baby F and baby L, unrelated babies targeted months apart, both experienced sudden, profound drops in their blood sugar levels. Hypoglycemia in neonates is not uncommon, but the severity and persistence of their low blood sugar were highly abnormal. To correct this, doctors ordered increased concentrations of glucose to be administered intravenously, yet the baby's blood sugar remained stubbornly, dangerously low. It was as if their bodies were rapidly consuming the sugar the moment it entered their veins. Blood samples were drawn and sent to a specialized laboratory in Liverpool for analysis. The results of these tests provided the smoking gun the investigators desperately needed. To understand the forensic significance of these blood tests, we must look at the biology of insulin. When the human pancreas naturally produces insulin to regulate blood sugar, it produces it in a precursor form called proinsulin. This precursor splits into two equal parts, the active insulin molecule and a byproduct called C-peptide. Therefore, in a naturally occurring state, the level of insulin and the level of C-peptide in the blood should be roughly equal. Synthetic insulin, the kind manufactured for diabetic patients and kept in hospital dispensaries, does not contain C-peptide. It is purely the active hormone. When the laboratory analyzed the blood of baby F and baby L, they found insulin levels that were off the charts, infinitely higher than a baby could ever naturally produce. But crucially, the C-peptide levels were virtually undetectable. This was undeniable, irrefutable biochemical proof that the insulin in their systems was exogenous. It had been introduced from the outside, Furthermore, the hypoglycemia only resolved when the baby's intravenous feeding bags were replaced. The investigators realized the horrific truth. Letby had covertly injected synthetic insulin into the very bags of nutrients keeping these children alive. She turned their lifelines into delivery systems for poison, knowing that the slow drip would mask the exact moment of her intervention and give her an alibi. The C-peptide finding was the key that unlocked the entire case. Without it, the defense could have argued that the babies had some rare, undiscovered metabolic disorder. With it, there was no medical explanation, only a criminal one. The mechanics of the poisoning and the statistical certainty of her presence point to the how. But the most disturbing aspect of this case is the why. Dissecting the psychology of Lucy Letby presents a terrifying void. She did not fit the traditional profile of a healthcare serial killer. She did not seek the thrill of resuscitation, playing God by bringing a patient to the brink of death only to save them, a phenomenon sometimes known as a hero complex. She often stood by passively or acted unusually detached while others fought desperately to save the babies she had harmed. She did not have a tragic, abusive background that armchair psychologists often look for to explain such profound evil. She was raised in a loving home, had friends, went on vacations, and lived an outwardly remarkably normal, mundane life. There was no grand manifesto, no discernible financial motive, and no history of severe psychiatric illness. Instead, investigators found a quiet, insidious malice. During searches of her home, police discovered handwritten notes hidden in her bedroom. The most infamous of these was a chaotic scattering of thoughts scrawled on a green post-it note. Amidst expressions of frustration and self-pity, she had written, "I am evil, I did this," and "I killed them on purpose because I'm not good enough to care for them." While the defense tried to frame these notes as the ramblings of an anguished, overworked nurse wrongly accused, the prosecution presented them as the closest thing to a confession the world would ever get. Those notes, crumpled and hidden, became a window into a mind that had rationalized the irrational. They were not the cries of a broken woman. They were the cold admissions of someone who knew exactly what she had done and chose to document it anyway. Further peeling back the layers of her psyche revealed a morbid, voyeuristic compulsion. Digital forensic analysts examined her electronic devices and found thousands of Facebook searches. She was repeatedly looking up the parents of the babies she had murdered or attacked. She would search for them on Christmas Day, on the exact anniversaries of their children's deaths, and late at night. She would scroll through their public posts, silently observing the unending grief she had orchestrated. It suggested a person who drew a quiet, sadistic satisfaction from the profound suffering of others, a suffering she had secretly authored while wearing the mask of a compassionate caregiver. This behavior, this return to the scene of the crime through a screen, is what criminal psychologists call reliving. It is not remorse. It is not guilt. It is the savoring of power over those who can never know they are being watched. Throughout the grueling 10-month trial, Letby sat in the dock, often impassive and detached. The defense argued that the Countess of Chester Hospital was a failing unit, chronically understaffed and plagued by poor medical practices. They suggested a confluence of natural causes, unfortunate coincidences, and scapegoating by senior doctors eager to cover up systemic failures. But the prosecution systematically dismantled this defense. They brought forward leading medical experts who reviewed every chart, every blood test, and every radiograph. One by one, they ruled out infection, congenital defects, and natural disease, They left only one medically viable conclusion: deliberate, calculated harm. The defense's theory that a hospital could accidentally kill 7 babies and injure 6 others in ways that perfectly mimicked deliberate poisoning required the jury to believe in a miracle of coincidence. The prosecution's theory required them to believe in a monster. The evidence made the choice clear. The jury's verdicts in August 2023 confirmed what the statistics and forensics had long suggested. Lucy Letby was found guilty of the murders of 7 babies and the attempted murders of 6 others, cementing her place in history as the most prolific child serial killer in modern British history. She was sentenced to a whole life order, meaning she will never be released from prison. But a verdict, no matter how definitive, cannot fill the void left by such a profound betrayal. It cannot restore the futures stolen from 7 infants. It cannot erase the trauma of the 6 who survived. And it cannot answer the question that haunts every parent who ever left a child in that ward: how did no one see it sooner? The anatomy of this case is terrifying, precisely because of its banality. The poison was not a rare exotic toxin, but a common hormone available in any hospital. The weapon was not a blade, but the very air we breathe and the milk meant to nourish. The perpetrator was not a lurking monster, but an ordinary woman in blue scrubs who smiled at parents, comforted them in their darkest hours, and then returned to the ward to systematically dismantle the lives of their children. The true horror of the Lucy Letby case lies not just in the forensic evidence or the clinical statistics, but in the chilling realization that the darkest malevolence can exist entirely hidden beneath the brightest fluorescent lights of a sanctuary of healing. This has been Anatomy of Crime, where the truth is never simple, but always worth seeking.